So before you learn anything else about more cardiovascular drugs, I have to review a couple of things for you. Things that you should have learned along the way, but maybe need a little refresher on. First of all myocardiocytes, every single heart muscle cell, whether it's in the ventricle or the atrium, have these properties. They all have automaticity. They're all able to generate a heartbeat, to start a heartbeat, to be a pacemaker, essentially, or to cause an abnormal heartbeat like a PAC or a PVC. Every single cell has excitability. That is the ability to respond to an impulse from a neighboring cell. Okay? They all have conductivity. That's the ability to transmit an impulse from one cell to another. So the way to remember these is a rogue cell in the ventricle, for instance, that starts a PVC. It has excitability. It has automaticity that generates the impulse. The cells next to it are ready to respond because they have excitability, and when they send that to the next cell, that's conductivity. They're conducting it from themselves to the next cell. Okay? Also, all cells have refractoriness. They all have a period of time where they can't respond to another impulse. And that refractory period is while they're doing their depolarization, and for a short time after that as well. And then finally, all heart cells have contractility. That's another capability of the cell. They all have the ability to contract in a heartbeat. So those are important things to remember, particularly the first four as they relate to electrical abnormalities of the heart. Now, normal conduction of the heart starts with a pacemaker cell, and that collection of pacemaker cells usually is in the upper right atrium, and we call that the SA node or the sinoatrial node, or because we're lazy, we sometimes just call it the sinus node, right? And that sinus node generates an impulse every 60 to 100 times a minute, and that's what we call normal sinus rhythm, right? When it arises from the sinus node and 60 to 100 times a minute, it generates that impulse. As long as those impulses start above the AV node, in the atria somewhere, they usually conduct down through the His-Purkinje system and have a narrow complex. But beats that originate in the ventricle, so for instance here, those beats would be wide complex because they don't follow this normal pathway. You see, this pathway that we call the His-Purkinje system, if you notice the bouncing ball here that enters at the AV node, takes a little rest, and then it comes down here, you'll notice that at the exact same moment, the impulse ends up here in the left ventricle and here in the right ventricle. And that's to make sure that everything is coordinated so that the right ventricle beats at the same time as the left ventricle. Now, the really important thing here is this AV node. And the AV node is kind of a switch in the heart that regulates the conduction of impulses from the top part of the heart, the atria, to the bottom part of the heart, the ventricles. It is the only way that impulses get from the atria to the ventricles, unless you have Wolff-Parkinson-White or some accessory pathway, but that's beyond our interest right now. So the only way to get down through get down to the ventricles from the top is for an impulse to go through the AV node. And the AV node does a couple of things. One, it slows down and halts that impulse. And why do you think it halts that impulse for a fraction of a second? Well, because the atria have to contract and eject blood into the ventricles, and that takes time, right? So the AV node regulates that, giving the ventricles enough time to fill. And then, once there's been enough time for them to fill, then it sends the impulse down through the His, right? This is the bundle of His, and the Purkinje system through these bundle branches, the left bundle and the right bundle branch. And then this is the Purkinje system, where these little tiny fibers from the bundle branches allow the ventricle to conduct all at the same time. So we record all these things on an EKG, an electrocardiogram, and we know that the P wave represents atrial depolarization, right? We say depolarization, not contraction, because this is an electrical representation. We don't know if it's contracting. We just see the electrical phenomenon, which is the P wave indicating depolarization of the atria. And almost always that means contraction of the atria, but we say that there's depolarization, okay? Then there's atrial repolarization, which gets buried in here. We don't see a wave associated with that. And then after the AV node lets it through, this period of time, this PR interval, is a function of the AV node health, right? When it's normal, then there's a normal amount of time for the ventricles to fill. And then it causes the AV node to send the signal down the His-Purkinje system, and then we get the QRS. The Q wave is the first downward deflection of the QRS complex. The R wave is the first upward deflection, and the S wave is the rest of it. And then there's ventricular repolarization, which is shown in the T wave. And sometimes you see a U wave. That was one of the things I was trying to show you recently. I have an EKG of somebody who had a magnesium level of 1.3 or something, and a potassium level that was really low, and that makes the U waves come out. So we usually don't see U waves, but when we do, don't be surprised. Okay? So that is the electrocardiogram. Those are the parts of it. That's what all that stuff means. So remember I told you earlier that when the impulse starts in the ventricle, it doesn't follow that normal conduction system, and so it takes longer, right? So this QRS complex is wide. It's wider than 120 milliseconds. Or, 100 milliseconds, which is like 2.5 small boxes. So since this is a wide complex, where do you think this impulse is coming from? Well, it's coming from the ventricle, because it's not following that normal His-Purkinje system. It has to send the impulse to the excitable cell next to it, which conducts it to the excitable cell next to it, and it takes a lot longer to go that way than it does to go down that His-Purkinje system. So again, normal sinus rhythm, we have a P wave for every QRS. That P wave is the atrial depolarization. There's a period of time here between the beginning of the P wave and the beginning of the QRS complex. That's a function of the AV node health. And in this case, it's normal because it's less than one large box, or 200 milliseconds or 0.2 seconds. Less than 0.2 seconds is normal. And then we have the QRS complex, and then we have the T wave, and then it repeats all over again. And the rate is 300, 150, 100, 75. So it's about 72 or so. Okay, so that's normal sinus rhythm. This is a PVC. It's big and bizarre looking and has a different appearance than the normal conduction beats. It's also early. So those are the characteristics of a PVC, or a ventricular beat. Sinus tachycardia, of course, tachy means fast, cardia means heart. So sinus tachycardia means it's coming from the sinus node. So we should have a P wave for every QRS, and we do. Notice it's buried in the T wave because it's going so fast. But this is a P wave right here. And so since the heart rate is faster than 100, and there's a P wave for every QRS, we have sinus tachycardia. And we see sinus tachycardia all the time in sick people, right? Because the heart needs to provide more blood to the body for fevers, for anemia, for dehydration, when people are just sick and trying to heal, if they have pulmonary embolism. There's a million reasons for sinus tachycardia. But know that it is a response to something else. So you may need to figure out what else is going on with the patient. My nemesis is atrial fibrillation. There are two characteristics of atrial fibrillation. Do not let this fool you in clinical. This is a very simple diagnosis to make. Don't overthink it. The two criteria are an irregularly irregular rhythm, right? So the distance from here to here is different than the distance from here to here, which is different from the distance from here to here, which is different than this distance, which is different than this distance. It's irregularly irregular. It's just a mess. It's chaos, right? So irregularly irregular rhythm and no discernible P waves. That's it. Don't let anybody make it more complicated than that. That is the definition of atrial fibrillation, okay? Don't worry about whether you see little squiggly lines here in the baseline. Sometimes you don't. There is such a thing as fine AFib. So these two characteristics are it. Irregularly irregular rhythm with no discernible P waves. Memorize that. Learn it forever. Don't let anybody make it more complicated than that, okay? There's also something called paroxysmal, which means it happens whenever the heck it wants. Supraventricular, which means it happens in the atria. Tachycardia, meaning fast heartbeat. We call this PSVT, and this is when somebody has a heart rate greater than 150 beats per minute. It originates above the ventricles, so the QRS complex is narrow. Usually. Sometimes it can be wide, but that's a different discussion. All right. So narrow complex tachycardia, greater than 150 beats per minute. We call this SVT. And then there's ventricular tachycardia, where it's wide complex. The rate's more than 150. And this can be life-threatening because it can, it doesn't have good cardiac output. The heart doesn't tolerate this well. And you can go right into ventricular fibrillation from this. And this is a special type of ventricular fibrillation called torsades. So I've had students in class who took French who say this in a beautiful way, but to the rest of us, it's Torsades de Pointes, right? I think it's pronounced Torsades de Pointes or something like that. It's very beautiful when people say it, but it's very ugly when you see it on the monitor. And this is an emergency. This patient is dead or dying. This is a lethal ventricular dysrhythmia. It's associated with a long interval from the Q wave to the end of the T wave. We call that the QT interval. And it's often seen with certain antiarrhythmics that we're going to learn about today. The treatment is IV magnesium, and it makes it go away. And of course, taking away anything that prolongs the QT interval, like amiodarone, the drug that we're going to talk about shortly. So, a couple of things about antiarrhythmics before you get to class. I want you to know that this is the action potential that you all learned about. Remember, there's phase 4, there's phase 0 when the sodium comes in, there's phase 1 when the potassium and chloride go out, there's phase 2 where the calcium influx happens. There's phase 3, where the potassium efflux happens. And then there's phase 4, when everything goes back to normal again. All right. And we have these different medicines that can affect each of these phases. This shows the different types of action potentials. If you ever wanted to know why the SA node can speed up and slow down, it's because of phase 4. So phase 4 has a variable pitch to it. If we want the heart to go faster, the phase 4 slope goes up, it makes it faster. If we want to slow down the SA node, or if your heart wants to slow it down, it will prolong phase 4 and make it a lower slope to slow the heartbeat. That's kind of cool, right? And then we get down to the ventricle. We get down to the ventricle, which is the action potential that you're accustomed to seeing. But there are different action potentials depending on where in the heart we're talking about. The SA node, the AV node, and the ventricle all have different effects. So we can classify these antiarrhythmic drugs based on the site of action. So we have class 1 drugs up at the top that work by prolonging phase 0, right? The sodium influx. So these are sodium channel blockers. 1A is the intermediate ones. 1B is the fast sodium channel blockers, and 1C is the slow sodium channel blockers. The one that we're going to study is lidocaine. You may also see flecainide given. We rarely use the 1A agents anymore, like procainamide and quinidine and things like that. But lidocaine is the sodium channel blocker that you are accustomed or will be accustomed to using for patients who are coding. Notice that we have beta blockers here that decrease the automaticity. They're technically classified as class 2 agents. We never say class 2 agents. And calcium channel blockers are class 4 agents. We never say they're class 4 agents, right? We just say beta blockers or calcium blockers. So because they are special cases, they don't have the downsides of antiarrhythmics that we're going to be talking about today, like the fact that lidocaine can kill you, and amiodarone can do the same, sotalol, ibutylide, all these other ones, flecainide can kill you. So we keep beta blockers and calcium blockers separate, and we just call them by their names. We don't say class 2 or class 4. The class 3 antiarrhythmics are potassium channel blockers. And remember, potassium channel blocking happens in phase 2, phase 3. And so that's why it's shown this way. Oops, where's my cursor? It's shown this way because this is phase 2 and 3 that are being prolonged. Amiodarone is the one that we're going to use as the class effect here. And use that as our prototype. It's the most commonly used class 3 antiarrhythmic, and there are reasons for that I'm going to explain to you. And then there's this other one down here at the bottom. Again, we don't call these class 5 agents. We just gave it a number because it's fun. We call these by their name. We call them DIG, we call them adenosine, we call them MAG. Those are the words that we're going to use. We're not going to call them phase 5 or class 5 antiarrhythmic drugs. Okay? So the benefits of antiarrhythmics are that they restore normal heart rhythm. They can prevent people from passing out from arrhythmias. They prevent deadly ventricular arrhythmias. And so that sounds great, right? So why isn't everyone on antiarrhythmics? Well, we tried that. We tried something called the Cardiac Arrhythmia Suppression Trial, or CAST. If you ever hear cardiologists talk about CAST, it's to remind us that these drugs are potentially deadly. So what we did in the CAST trial in the 80s was we noticed that people who had had an MI often had a lot of ventricular ectopy, a lot of PVCs, some non-sustained ventricular tachycardia. And we were very concerned about that because we thought those were probably the people who were going to die suddenly. So we created a trial where we loaded people into a trial and they got either placebo or they got one of these two antiarrhythmics, which are 1C agents called enconide or flecainide. You remember me saying flecainide. The enconide, by the way, this should tell you what happened in the trial. Enconide is no longer on the market. It died as a result of this trial. So this is a Kaplan-Meier survival curve, and it shows the patients without an event of sudden death. And the placebo did way better than the people who were randomized to enconide or flecainide. So this taught us that we have to be very, very careful about who we put on antiarrhythmic drugs. And this gave everybody pause about which antiarrhythmic drugs we should use and under what conditions. And that's where we're going to pick it up when we talk about antiarrhythmic drugs this week.